located. My name is Lauren Stiles. I'm the president and co-founder of Dysautonomia International, and I'm pleased to be moderating today's webinar with some very special guests. We're going to talk about rare autonomic disorders. Yesterday was Rare Disease Day, and today kicks off, March 1st kicks off MSA Awareness Month, and MSA is one of the rare types of dysautonomia we'll be talking about today. With that, I'm going to turn it over to Dr. Stephen Vernino. I hear an echo, sorry. Who is one of our medical advisory board members and one of the leading experts in the world in autonomic neurology and some of the rare autonomic disorders he's going to talk to us about today. So Dr. Vernino, you can take it from there.
Thank you, Lauren. I appreciate it. I'll just put some slides up here. I'm at UT Southwestern. As you heard, I'm joined today by our autonomic fellow, Dr. Kishan Tarpara. So their autonomic disorders are very important, and we're trying to grow the field of doctors that really know about these diseases. And part of that is to create fellowships in autonomic disorders. And there's only 5 or 6 of those around the country. So you'll hear from Dr. Tarpara along the way here. So we're talking today about rare autonomic disorders. There's obviously a lot of more common ones, but I wanted to start off talking about, and these are the ones we'll talk about. I want to start off talking about autonomic disorders in general, because there's lots of things that affect the autonomic nervous system. There's a group of disorders that fall into the category of neurodegenerative conditions. In other words, the nerve cells that control the autonomic nervous system degenerate. And it's interesting that many of these disorders fall into a category called alpha-synucleinopathies, called such because there's a protein called alpha-synuclein that is part of the problem in these disorders. And that's been a fairly recent understanding of them and may lead to some important therapies down the road. And we'll talk more about alpha-synuclein as we go forward. There's also a group of conditions, some of which are rare, that can affect the autonomic nervous system due to the immune system attacking the autonomic nerves. And so there's a number of these that are probably autoimmune. And then there's a group of disorders that are quite rare, where there's abnormalities in genes that are important for the autonomic nervous system and can lead to inherited forms of dysautonomia. So this is a broad overview, and we'll talk about some of these as they're categorized as rare autonomic disorders. So firstly, multiple system atrophy. This is a rare disorder. Unfortunately, it is also a progressive and fatal neurodegenerative disease. It's estimated that there's about 4 to 5 per 100,000 Americans with MSA, which translates into about 12 to 15,000 affected persons in the United States. So it's a small number, but this is a group of patients that have pretty significant difficulties, and we are focusing on these in research because of the fact that this is a progressive and fatal disease, and we'd like to do a better job at offering treatment. So the onset is usually in 50 or 60-year-old people. It can look somewhat like Parkinson's disease, although it's more rapidly progressive than Parkinson's disease, and patients unfortunately lose their ability to ambulate roughly 3.5 to 5 years after the presentation. And the mean survival time from symptom onset is about 8 years. So there's quite a variable, quite a variability in different patients, and it depends on how you define the first symptoms of the disorder. Right now, there's no disease-modifying treatment, so we spend our time managing a variety of symptoms that these patients have, and do a lot to try to provide palliative care, support for their caregivers, and education. So these patients initially can present in a number of ways, but the autonomic symptoms are often prominent at the beginning, including orthostatic hypotension, lightheadedness when they stand up, even fainting, and bladder issues. So bladder is often involved early in multiple system atrophy. And then along with that, we see troubles with balance, either shuffling gait or unsteadiness. And so when we see this combination of balance trouble, gait problems, and autonomic issues, we have to think about multiple system atrophy, although there are other conditions. Interestingly, in all of the alpha-synuclein disorders, there can be some prodromal symptoms. And that what that word means is that these are symptoms that may be present even many years before the disease kind of presents itself. And two of the common prodromal symptoms are REM sleep behavior disorder. This is a condition where people act out their dreams, and instead of sleeping quietly while they're dreaming, they may act out, particularly if they're having a dream about being threatened, they may be punching and kicking. And that can be quite dramatic. And our sleep doctors recognize that REM sleep behavior disorder may be the first signs of one of these alpha-synuclein disorders. So there's a lot of interest in perhaps intervening way back when someone's having a sleep disorder, if we had a treatment that might prevent the development of Parkinson's disease or MSA. And then constipation is a common prodromal symptom, although of course, constipation is very common. We do a lot of different things. And so this falls on a spectrum. You can see synucleinopathies are multiple system atrophy, Parkinson's disease, this condition called diffuse Lewy disease, which causes memory problems, and also one called pure autonomic failure. And this is, again, a rare autonomic disorder where patients have autonomic failure, orthostatic hypotension, predominantly, without any of the other symptoms. And so when someone presents, again, in middle to late age with fainting, low blood pressure when they stand up, without another cause, we can think about the possibility that it's pure autonomic failure. And that's to differentiate from another set of diseases called the tauopathies, where the protein that builds up in the brain is called the tau protein rather than alpha-synuclein. And that's where Alzheimer's disease and some other things live. So in MSA, I like to think about the 5 Bs. So patients with MSA have balance problems. And then with their autonomic failure, they typically have blood pressure problems. Their blood pressure can be quite high when they lay down and very low when they stand up. They get bladder issues, they get bowel issues, and eventually they may develop breathing troubles with incoordination of their breathing muscles. I mentioned REM sleep behavior disorder. So these patients may present to neurology, of course, but sometimes to the urologist or the cardiologist or even sleep medicine doctor. So we treat MSA as a team with multidisciplinary care, and that's what we focused on with our patients. There's a lot of research going on, but as of now, we have good treatments to manage the symptoms, but not really to change the course of the underlying disease. So again, a lot of the data recently has been focused on this alpha-synuclein protein that seems to, although it's a normal protein, as it causes disease, it starts to accumulate in these complexes called fibrils, which can then deposit in brain cells as inclusions. And in the case of multiple system atrophy, these accumulate in the oligodendrocytes, which are some of the supporting cells in the brain that support the nerve cells. And they form these glial cytoplasmic inclusions that we can see at autopsy, although we don't really have a good way of finding them in the living patients, because we don't really take brain biopsies, although there's some technologies being developed that may help us find the alpha-synuclein in other tissues. And there's some interesting data that's developing about how the gut is involved with a lot of these conditions. The gut is very involved in inflammatory processes, but also it's thought that perhaps the alpha-synuclein, which are these little blue squiggles here, may actually initially form in nerve cells in the intestinal tract, and then may travel through the vagus nerve to get into the brain. But these are some interesting hypotheses with some data behind them that may eventually lead to a better understanding of these degenerative conditions. So at autopsy, we often see in MSA patients is that the lower parts of the brain, so this is the cerebrum, the thinking part of the brain that looks pretty normal. Back here is the cerebellum, that's the balance center of the brain. And often in MSA, this part of the brain is very shrunken. as well as the brainstem. And you may know that the autonomic control centers live in the brainstem and the hypothalamus of this part of the area of the brain. And this also shows a lot of shrinkage in multiple system atrophy. So in later stages of the disease, we can see these on the MRI scan, and that helps make the diagnosis, but often not in the early stages. When these patients come to autopsy, they have some accumulation of alpha-synuclein in nerve cells. So here's some picture of the brain with various nerve cells, these are the big ones. And if you stain for alpha-synuclein, you'll see these inclusions that actually live in the glial cells that surround the neurons. And so certainly you can make the diagnosis after death. So that's the challenge in many of these rare diseases we'll talk about today, that making the diagnosis with certainty can be a challenge. So we can only make the diagnosis of definite multiple system atrophy at the time of pathology. And of course, that's a little bit late to be able to be sure and to do something about it. So during life, we talk about probable MSA, and those are patients who have severe autonomic failure, often with bladder involvement, some Parkinson, something that looks like Parkinson's disease, although maybe not quite Parkinson's disease, or with ataxia, which is a balance problem. And then we see a progressive course and no other good explanation. We often encounter possible MSA earlier on when the symptoms are suspicious, but we don't have all the full range of the symptoms. And in those cases, we can't entirely be sure. Maybe it could be we're dealing with regular old Parkinson's disease or some other disorder. But again, we're developing some better tests over time. And so during life, we can be more and more sure. There's some findings that we see on the MRI scan that are very convincing for multiple system atrophy. And we don't see this kind of finding. This is called the hot cross bun sign in the brainstem. We really don't see that in other disorders. And then more recently, there's been some technology where we can actually take a biopsy of the skin and see the alpha-synuclein there, which can help tell us that we're dealing with one of these degenerative conditions and help us also in some ways differentiate from Parkinson's disease. So that's not so important right now because we don't have a treatment for MSA, but earlier diagnosis is going to be very important when we do develop treatments that can treat this protein and help to slow down the disease. There's other biomarkers in development, so I think over the next few years we'll be able to more definitively differentiate multiple system atrophy from Parkinson's disease. This is an assay that's done on spinal fluid, where one can measure the level of the alpha-synuclein and its ability to form these inclusions from a sample of the spinal fluid. So why is diagnosis difficult? Well, MSA is a rare disease, and that means that many doctors will never see a case of multiple system atrophy, or even when they do see it, they haven't seen enough cases to recognize what they're seeing. And oftentimes other diagnoses are much more common, like Parkinson's disease or orthostatic hypotension due to other causes. And many of the symptoms, at least initially, can be not specific, such as the dizziness, the bladder problem, bladder urgency, balance difficulties. And these biomarkers I talked about in the last couple of slides are exciting, but not yet readily available commercially. So again, for treatment, we treat MSA symptomatically. We're finding that patients can get better care if they are part of a multidisciplinary clinic where it's not just the neurologist, but also physical therapy doctors and urologists and others get involved. So that is something we're working on with the Multiple System Atrophy Coalition to try to develop that framework for these clinics. Research is underway for disease-modifying treatments. And we certainly recognize that these conditions, like with all autonomic disorders, put a big burden on the caregivers. So we focus a lot on education and caregiver support when possible. So the disease-modifying treatments would be to look at drugs that might target this alpha-synuclein and try to clean it up out of the nerve cells, or to use some drugs that might promote that might block the ability of the alpha-synuclein to collect in nerve cells. And inflammation also seems to play a major role. So a lot of the treatments that are being looked at are things that either support the neurons through growth factors, stem cells, block inflammation, or target the alpha-synuclein directly. And that's the challenge in research in rare diseases, is that we would like to target these diseases early, but the diagnosis can be challenging to make. And many of the drug studies want to enroll patients who are still functioning pretty well. In other words, have early disease, but at that stage, as I mentioned, the diagnosis may be unclear. The goal of the treatment so far is to slow down the disease. We aren't quite at the level of a cure. And assessing the severity of the disease can be pretty challenging. And there's a lot of work going on now in developing better scales for various autonomic disorders, including MSA and others. So I wanted to change gears a little bit. So MSA is one of those rare neurodegenerative diseases. There are also some autonomic disorders that are due to the immune system. And what's exciting about diseases like this is there are potential treatments. We have very good drugs that treat the immune system. And if we can make the diagnosis of a disease that's caused by the immune system, that might open up the possibility of some good treatment. So a disease I've studied for many years is autoimmune autonomic ganglionopathy. And first thing I will say about this disease, which I've studied for going on 20 years, is that it's very rare. There are really only a few hundred cases that are confirmed to be AAG and known and reported. But it's actually been around for a long time. The first published cases were in the late 1960s, early 70s. And what this condition looks like in its classic state is the sudden onset of severe autonomic failure. Autonomic failure means that the autonomic reflexes don't work. So there's often very severe orthostatic hypotension, the blood pressure dropping, sometimes even 100 millimeters of mercury when patients stand up. And the heart rate doesn't change, which means that the autonomic reflexes that would help to manage orthostatic hypotension are not working. These patients often have very severe GI motility problems, severe constipation, bladder retention, and some other things I'll talk about. But what's unique about autoimmune autonomic ganglionopathy, it affects the autonomic nerves and the autonomic ganglia only. So these patients have no evidence of sensory or motor neuropathy. Their sensation is normal. The EMG and nerve conduction tests are normal. If one were to check a skin biopsy, look at small fibers, those would be normal as well. Oftentimes these patients have a quote unquote viral illness at the onset of their symptoms. So that again suggests an autoimmune cause. What's useful is that we have a commercially available test which looks for antibodies against the ganglionic acetylcholine receptor, which is the cause for many of these cases of autoimmune autonomic ganglionopathy. So when we look at all of these cases that have been reported, a few hundred of them, it has a wide range of age, a slight predominance of women, often this subacute onset, and by that we mean over the course of just a few weeks rather than over years like we'd see in something like multiple system atrophy. Even without treatment, many patients get a little bit better, but typically their recovery is incomplete. In other words, they still have symptoms. So again, the symptoms are orthostatic hypotension. They can have loss of sweating, dry eyes and dry mouth, bladder impairment, sexual dysfunction. Often the heart rate is fixed, it doesn't change. Typically sits around 70 or 80 and doesn't move. And they may even have lack of response to light from the pupils, along with pretty severe GI motility problems. So we noticed many years ago that occasionally this condition can associate with other things that suggest an autoimmune cause, so like myasthenia gravis, another autoimmune disease, or with thymoma, a tumor of the thymus gland, which is often associated with autoimmune conditions. So this is the autonomic nervous system. What's unique about these peripheral autonomic nerves is that there's a nerve cell in the spinal cord, and it sends out information out to the body. And there's a relay center called the autonomic ganglia. And this is true both of the parasympathetic and the sympathetic nervous system. And even within the gut, there's lots of gut ganglia, like the myenteric plexus ganglia. And in all of these ganglia, there's a synapse. Synapse is a communication between two nerve cells. In this synapse, the first nerve cell releases acetylcholine as a chemical, and that interacts with receptors on the secondary neuron, and it's the second neuron that goes off to send instructions to the body, like the heart or the sweat glands or the blood vessels. So these ganglia, this receptor at the ganglia is the ganglionic receptor, and it's a ganglionic acetylcholine receptor. So the idea is that patients who have antibodies get into this ganglia and prevent the information from passing through. So in other words, the brain sends out the signals of what we want the body to do, but the autonomic nerves can't get the information to the heart and blood vessels and other places. And that leads to the symptoms of autonomic failure. And we typically now can look at this antibody in a couple of different ways, and I think this is where a lot of confusion tends to happen. So in autoimmune autonomic ganglia, in the classic form of this condition, patients have very high levels of this antibody. And this antibody is measured on a scale of either nanomoles or picomoles per liter. That's a measure of how much antibody there is in the blood. And patients who have AAG typically have antibody levels that are higher than 1 nanomole per liter. That's quite high. And in those patients, they have the full spectrum of autonomic failure with orthostatic hypotension, bladder doesn't work, pupils don't react to light, and all the rest. But even though that's a very dramatic characteristic disorder, because it's rare, I would say most physicians have and will never see a case of AAG. Now, there's also a group of patients who have lower antibody levels between, for example, 0.2 to 1 nanomoles per liter. Those are positive antibodies, but a bit lower than in the full-blown condition. And these are patients who have autonomic failure, but it may be a bit milder or more limited, or a bit more chronic in its development, so less dramatic, but typically still has orthostatic hypotension, GI problems, bladder problems, and so on. And these are a bit more difficult to diagnose because they can look like those neurodegenerative conditions like pure autonomic failure that I mentioned earlier. And then finally, there's patients who have lower levels of these antibodies, ganglionic receptor antibodies that are less than 0.2. And there's been a lot of analysis of these cases, these patients who have low levels of antibodies, and it turns out that this antibody, unfortunately, is pretty nonspecific at this low level. Nonspecific means that it doesn't allow you to make a diagnosis. It doesn't mean that it's totally irrelevant, but it has to be interpreted with some caution. In practice, the majority of patients with these low ganglionic acetylcholine receptor antibodies that we see actually don't have any autonomic or neurological disorder. And that's because the antibody is very readily available at a couple of different laboratories. But there are some patients who have autonomic symptoms, and the question is, what do these antibodies mean in those scenarios? So there are a group of patients who have postural tachycardia syndrome, maybe 3 to 5% of them that have ganglionic receptor antibodies at these low levels. But this is not autoimmune autonomic ganglionopathy. These antibodies may just reflect that there's an abnormality in the immune system going on. It should be noted also that if we looked at groups of healthy control patients, about 3% of them also have ganglionic receptor antibodies. So we have to be very careful about this antibody at these low levels. There's also a group of patients with unexplained GI dysmotility who have these antibodies, and the suspicion is maybe there's immune-mediated or autonomic or autoimmune form of this GI dysmotility that's going on in those cases. So AAG again can be hard to diagnose. Actually, the classical presentation is pretty characteristic, but unfortunately, many physicians have never seen it, so it's hard for them to diagnose a true case when it does come along. And there's a tendency to overdiagnose AAG in other scenarios. So in other autonomic disorders. So it's hard to diagnose because the symptoms can be similar to other autonomic disorders, including the neurodegenerative ones or other types of autonomic conditions. But the characteristic feature would be severe orthostatic hypotension, a big drop in blood pressure on standing without any tachycardia, along with constipation, urinary retention, and often slow pupil responses. And honestly, we doctors aren't very good at assessing pupil responses with a little flashlight. But if you use a more sensitive technique like we have in our autonomic lab, you can actually see some unique pupillary response abnormalities in these patients. So as I mentioned, the antibody test is very helpful in the right scenario, but certainly not a perfect test. It's important though, even though it's a rare disease, it's important to be on the lookout for it because it's treatable, and we've shown in some case series that plasma exchange and immunosuppression can be helpful by removing this antibody. And unfortunately, there will never be a randomized control trial because there just aren't enough patients in this condition. We can come back and talk about this more in the question and answer period. I wanted to change gears a little bit and introduce Dr. Kishan Tarpara. Again, he's the autonomic fellow at UT Southwestern. So he's already a fully trained neurologist and has been spending this past year with us, learning about some of these common and uncommon autonomic disorders. So Kishan's going to talk about a few rare genetic disorders.
All right. Well, good morning, everybody. So I'm going to talk to you a little bit about familial dysautonomia. It's also called Riley-Day syndrome, or hereditary sensory and autonomic neuropathy, or HSAN type 3. So it's a very rare genetic disorder of the autonomic nerves and among other tissues. So there's about 350 known patients worldwide at this point. So the origin of the disease, so there's a mutation in the gene that encodes a protein called ICAP, and we know this protein is important in the development of the nerves that send sensory information to the brain, and development of the sort of insulation sheath around the nerves. It's also involved in tissues other than the nerves, which I'll show you on one of the next slides. So let's repeat slide. So here's a little cartoon picture of basically the nature of the genetic abnormality in this disease. So on the left side, there's the sort of the normal pathway from the gene to the protein, that the normal functioning protein. In familial dysautonomia, there's the gene mutation results in basically one part of the protein that should be there gets removed, and this results in an abnormal protein that results in the complicated set of symptoms that we'll go over in a few minutes. So for most of the patients that have been identified with this disease, most of them have the same mutation, and this sort of traces back to Jewish population in Poland, going back a few hundred years. That's as much as has been able to be discovered about the origin of this particular mutation. And then this picture on the right lower side is comparing, basically showing you which tissues that this abnormal protein is more common in. So you have this mutation, and it shows up, the protein you have normal protein and you have abnormal protein, and the amount of abnormal protein depends on which particular tissue you look at. And so this is just showing you that the nerve tissues, you're more likely to have this abnormal version of the protein compared to other types of tissues in the body. And so the characteristics that you see when patients come in with this condition, so the most notable thing is the cardiovascular autonomic reflexes are not working as they should, and that results in a lot of the symptoms that these patients deal with. But there are also, as the name implies, there's a sensory component to this as well. So these patients have impaired pain and temperature sensation. So one of the tests we do involves submerging a limb in ice water for a minute or two, which is not comfortable, but because of that pain signal, that triggers the release of norepinephrine and results in the changes in blood pressure that you see. But in patients with this disorder, you don't see that normal response that you see that you would expect in a normal person. They can also have abnormal taste and swallowing. Their movements can be uncoordinated, and they get episodes or sort of attacks of autonomic symptoms with sort of adrenaline surges. So these sort of adrenaline stress hormone type symptoms, high blood pressure, fast heart rate, sweating, fever. The interesting thing about these episodes is that there is vomiting is often accompanies these adrenaline surges, which is not what you typically see with these sort of autonomic storms or these type of episodes in other conditions. So we'll talk about the cardiovascular autonomic symptoms that these patients have. So the root of the issue is what's called afferent baroreflex failure. So there are sensors in the neck and in parts of the large blood vessels that basically detect changes in blood pressure and regulate the heart rate and the blood pressure based on those readings. And so the picture on the right side, so the top is a normal 20-year-old male. The lower part of the picture is a 17-year-old male with familial dysautonomia. And on the top, the normal patient you see is the blood pressure is kept within a pretty narrow range. Even during sleep, it dips down a little bit, but it stays in a pretty narrow range and pretty consistent throughout the day. But with familial dysautonomia, the thing that stands out is the sort of fluctuations, the changes in blood pressure with just throughout the day with certain activities. In this note here, so these are measurements from an ambulatory blood pressure monitor where they check blood pressure every 15 minutes for looks like 24 hours or so. And they made the notes here that there's the patient gets anxious when they're in the doctor's office, or if they're engaged in some intense sort of cognitive activities, like playing a video game, that results in increase in blood pressure. So that's an interesting thing that you don't see in other types of dysautonomia, is this very sort of tight involvement of sort of cognitive arousal, a level of cognitive stress, and how that ties in with the blood pressure that you see. And the next this next picture is showing what happens on a tilt table, which I'm sure many of you have gone through. So the heart rate is shown on the top and the blood pressure on the bottom. And again, what we see, they point out here that the patient is talking. So anytime there's sort of cognitive or emotional stimulus that has a direct correlation with your sympathetic activity in the brain and results in the changes in the blood pressure that you see. The interesting thing with so baroreflex failure can happen with other things that can cause baroreflex failure, like radiation to the neck or surgery. But those other causes of baroreflex failure, you don't see these particular characteristics. So orthostatic hypotension, which means blood pressure drops when you stand up. In a normal person, if their blood pressure drops, you'd expect the heart rate to go up based on the reflexes. But in familial dysautonomia, you don't see an impairment of that. You see a reversal of that heart rate response, which is pretty unique in familial dysautonomia. And then the other thing I mentioned on the previous slide is that the cardiovascular responses to emotion are more pronounced. So those are there in normal people and other people with other types of dysautonomia, but in these patients, the direct connection between the cognitive and emotional centers in the brain and the sympathetic activity, that connection is more prominent in these patients. So next is, so the way that we treat and sort of counsel patients with this is that, so it's a genetic disease, and it's sort of a complicated genetic problem. So we don't have treatments to address the underlying issue. So treatment is mainly centered around symptoms and prevention of complications from the disease. So treating the symptoms of the autonomic storms, that can involve medications like benzodiazepines or clonidine, and those sort of having to balance the side effects from these medications with relief from the problematic symptoms. But then the other thing is watching for complications of high blood pressure. So these swings in high blood pressure, they can go from too high to too low. But in general, the patients can have high blood pressure, especially when they're sleeping, and over time this can cause problems, specifically, mainly with the heart and the kidneys. And so you want to monitor for complications with the heart, just from this high blood pressure. And one of things to point out is fludrocortisone is a medication that's used often for syncope or orthostatic hypotension or dizziness related to low blood pressure. And in this particular set of patients, fludrocortisone has been shown to actually worsen the supine hypertension. So the blood pressure when you're lying down, laying flat, can be too high, and over a long period of time that causes problems, including worsening of kidney disease or kidney problems. And so we're getting ready to look at this potential for people who have been on fludrocortisone for a long period of time. In otherwise normal, healthy people, does fludrocortisone, can you see these sorts of problems crop up in a different set of patients than familial dysautonomia? So that's the project that we're getting ready to start looking at and collecting some information, and that's all I have on this condition. So a few other rare autonomic disorders to mention. So adrenal insufficiency that can have lots of different causes, with the adrenal glands themselves or with the pituitary gland, that sort of sends commands or directions to the adrenal gland. So that's not a single condition, but something that can take a variety of presentations. Alachromia, that means not making tears, not producing tears. It's one of the functions of the autonomic nervous system, that's producing tears and saliva and all these sort of automatic functions. Achalasia, which is goes along with some rheumatologic disorders or autoimmune disorders that results in painful spasms of the lower esophagus. And then DBH deficiency is another sort of genetic disorder where you have a deficiency of a specific enzyme that is required to make the neurotransmitters or the chemicals that are required to have normal blood pressure and autonomic regulation, specifically blood pressure. So again, these are rare disorders, but good to know. And we often learn a lot about what's normal function from studying these rare diseases.
And again, this is an example of this DBH deficiency. As you can see, there's only a small handful of cases, but because we know the precise enzyme deficiency, there's a medication, you've probably heard of droxidopa, but droxidopa is uniquely effective for these patients. So just to wrap up, and I think we'll have plenty of time to field some questions. As a group, autonomic disorders are quite common, and certainly we know there's a lot of patients who have POTS. There's a lot of patients who have orthostatic hypotension and syncope for other reasons. But as Kishan said, it is important to pay some attention to these rare conditions because they do give us some idea, some insights into how the autonomic nervous system works based on how it doesn't work when things go wrong. And these rare autonomic disorders can have a different prognosis. Sometimes, as in the case of MSA, it's not a very good prognosis. And in other cases, such as the DBH deficiency or AAG, there may be different treatments that may be uniquely effective in managing those patients. So we'll stop there if that's okay. And
That's great.
Yeah.
So I wanted to invite everyone, some people have already done this, but I wanted to invite everyone to type some questions into the Q&A if you have any questions. Please don't ask specific medical questions about your own situation or your family members. Try to keep it a more generic question because the doctors obviously can't give medical advice over a Zoom webinar to someone they've never met. And I'm sorry if we can't get to everyone's questions because there's always way more questions than we can get to, but we try to look at what a lot of people are asking about and then try to touch on those questions. So the first question is actually about a rare genetic disorder that can cause dysautonomia in some patients. And I was just wondering, Dr. Bernino, if you could briefly tell us a little bit about Fabry's disease and how rare it is and when would you look for that in someone with dysautonomia?
Yeah, maybe Kishan can look up the exact, it is a rare disease, but as far as the exact prevalence of that one. So it brings up an interesting point, and I think this was true when Kishan was talking about familial dysautonomia, and that is that there's a similarity between autonomic nerves and some of the sensory nerves that are called the small fibers. And so Fabry's disease is a metabolic disorder where there's an enzyme deficiency that causes damage to the small fibers, and that can lead to both small fiber neuropathy, which is typically characterized as being painful. So a painful neuropathy along with some autonomic dysfunction. So I think when we see autonomic problems or dysautonomia associated with painful neuropathy, and that's a little bit different than pain because people can have pain and not have neuropathy. But if there's really evidence of a small fiber neuropathy, that's one of the things we think about. And then there's a few other characteristics of Fabry disease. There's a kind of a unique skin rash that can be seen in those patients. If I'm not mistaken, the genetics are that it's more commonly seen in boys compared to women. And Kishan maybe has found, tell us what the exact enzyme that's involved here, but it can be tested for in some laboratory tests.
I actually want to chime in with something. So we actually know there was one Fabry's POTS case report from Dr. Shalimsky, who was a POTS patient that had regular old POTS who ended up getting diagnosed with Fabry's. We know of 2 other patients who had a sort of a long-term POTS diagnosis and then eventually found out that they had Fabry's. And the trick with it is that there's like 600 different genetic mutations that can lead to a Fabry's diagnosis, which probably means there's 601 and we haven't found all of them yet. So this is something that I know the patient is asking this question, do you think that is there anyone doing in the autonomic world doing research on Fabry's, or is there anyone in the Fabry's world doing autonomic research that you know of?
Well, you can probably tell from my response, I'm not real
You're not
familiar
that guy.
with that field. But I know there have been some efforts, and I'm not sure where they're at or what's come of it, in looking at genetics in a broad range of dysautonomia in POTS patients. And I think that would be interesting to see how often does a Fabry mutation pop up in that. I think still going to be pretty rare, but that's an important one to think about.
Yeah. All right. So the next question, I saw you, Dr. Fernino, had answered some of the questions during the session, but can POTS turn into AAG, or can different autonomic disorders turn into, can AAG turn into MSA and et cetera? Can you explain how these are distinguished, and do they evolve into other conditions?
Sure. So that's why I started off by talking about different categories of disease. So, typically an autoimmune disease is not going to turn into a genetic disease, although some genetic diseases do lead to neurodegeneration, and inflammation can cause neurodegeneration. So there can be some overlap in that sense. But I think if you're thinking about, does one can there be an overlap in the presentation, or can one thing kind of merge into another? I think that's true. And of course there are, Lauren and I wrote an article about there being an autoimmune or immune mediated set of diseases that present as postural tachycardia, ranging from Sjogren's disease to a number of other things. But AAG in particular, because of the way it works, causes more of an autonomic failure presentation with the orthostatic hypotension, as opposed to POTS, which by definition does not have orthostatic hypotension. And we have seen a few cases of, and not to alarm anybody, of multiple system atrophy patients who early in the early stages did show a fair bit of tachycardia when they stood up. But that was only because at the early stages, their blood pressure was dropping, and they could still increase their heart rate some. But the key thing is that their blood pressure was dropping as well. So yes, things can evolve over time. I think as physicians, if we can't make a definitive diagnosis, we should sort of hedge our bets and say, this looks like such and such, but we don't really know which direction it's going. It could be that this will be what it is, or it may be evolving into something else. And we certainly see that a lot in our patients who present with orthostatic hypotension, and we don't really know why their blood pressure is dropping, and we end up calling them pure autonomic failure. And they may stay like that, or they may develop into MSA later.
So I wanted to ask a question for the recording that is something you discussed in the typed Q&A, but just to get it in the recording. So a lot of people wonder, can you have POTS and AAG? Is this different, the same? And if I know what your answer is, but can you elaborate on that, the fact that there's other autoimmune stuff that happens in POTS that a lot of doctors are, I guess I'm answering the question, but I should let you answer it.
Yeah, I think that the confusion comes about because, physicians, doctors like to make a diagnosis. And I think when they see an antibody or they suspect an autoimmune cause, they type it into their Google and AAG comes up, and they make the diagnosis of AAG. What they really mean is it's an autoimmune autonomic disorder. AAG, as I described it, has a very specific sort of characteristics to it. I think it's much better to say you have POTS, and I suspect it's autoimmune POTS or immune-mediated POTS, or you have an immune-mediated small fiber neuropathy with with dysautonomia, rather than use a specific diagnosis. Just like we wouldn't call someone with orthostatic hypotension, call them MSA unless they met the criteria. One could say I'm suspicious about it, but in terms of actually making the diagnosis. So in the case of POTS in particular, one of the things that's involved early in AAG, the actual disease, is that patients lose the ability to elevate their heart rate when their blood pressure drops. And so that's kind of the opposite of POTS, if you will. So in fact, we've even seen patients whose heart rate goes down when they stand up. It's an unusual paradoxical reflex that happens in severe autonomic failure. So I try with, when I discuss these things, is make the differentiation between autonomic failure and autonomic dysregulation, where, or partial, you can have partial autonomic failure where parts of the autonomic nervous system work and others don't. And that's in the scenario in which you can see excessive tachycardia, for example. But in AAG, really, the body's ability to increase the heart rate is impaired, so you would really not expect tachycardia. And if you have POTS and you've been told you have AAG, I think what the doctor's trying to tell you is they're suspicious you have an autoimmune type of autonomic disorder.
Are there other diseases, particularly autoimmune diseases, that cause that can cause an autonomic ganglionitis? And how do you distinguish that from AAG?
So there's one in particular, and that's paraneoplastic autonomic neuropathy or paraneoplastic autonomic ganglionopathy. So this would be a patient who has cancer, and as a result, their immune system gets activated, and then they start attacking their nerves or brain or what have you. And actually, GI problems like gastroparesis are pretty common in cancer patients, but in more severe cases, they can actually have inflammation in their autonomic ganglia, which causes damage to the autonomic nerves. And that can look a lot like AAG, although those patients typically have different antibodies, and of course have cancer. But at the time of the presentation, it may not be known they have cancer. So there are some patients who may look like AAG in terms of orthostatic hypotension and bowels not working and so on. And if they turn out they have an antibody such as the anti-Hu antibody, then we really would be suspicious about lung cancer rather than AAG. And then there's some data that actually patients who have severe diabetes have some damage to their autonomic ganglia. But I think they typically look like more like a neuropathy than a ganglionopathy. The only other scenarios I can think about would be there are other autoimmune diseases. For example, Sjogren's is thought to cause a ganglionitis which affects both the sensory ganglia, the DRGs, as well as the autonomic ganglia. So you can have these sensory and autonomic neuropathies, and I think it's important to recognize when there's a lot of sensory findings, or even if there's a suspicion of that. One thing I always look for, and is just as an aside, in patients who have autonomic symptoms and I suspect may have Sjogren's, look at their reflexes, their pupil responses, and also the gag reflex. I don't know if this has affected you, Lauren, but a lot of my Sjogren's patients don't have a very good gag reflex, and that's unusual. And of course, Sjogren's may have a different set of antibodies, but again, challenging because antibodies aren't perfect. They're not, at least the ones we have available. Sometimes we get false positives, and a lot of times we get false negatives. We do see patients who look a lot like autoimmune autonomic ganglionopathy who don't have any antibodies that we can see. And the reason we call it autoimmune autonomic ganglionopathy is because all the symptoms look right. And we may try to treat them with immunotherapy just based on that symptom complex of autonomic failure.
Just yeah. If you could just elaborate, because someone had asked a question during your talk. You didn't. I don't think you covered too much on seronegative AAG. Can you just explain that concept briefly?
Yeah. So as I mentioned, the clinical characteristics of AAG would be typically a rather sudden onset of autonomic failure. So this would be orthostatic hypotension, bowels not working, bladder not working. And so you can see that presentation, again, with orthostatic hypotension in patients who don't have ganglionic receptor antibodies and don't have paraneoplastic antibodies and don't have cancer. And we've termed that seronegative AAG. But as one of my other colleagues, Dr. Golden, and I looked into those cases more carefully, most of them also had some evidence of sensory neuropathy, so pain, loss of sensation, and so on, which makes one think that perhaps they have either a sensory and autonomic ganglionopathy, in other words, not just the autonomic ganglia, or a sensory and autonomic neuropathy. But the way it came on quickly, again, makes us think about an autoimmune cause. So when we looked at treatment in those patients, they often did respond to immunotherapy, but it was a bit different than AAG. And since plasma exchange wasn't all that helpful, and things like steroids and other things were more helpful. So again, pretty rare, but we do look at the clinical presentation as a big part of making these diagnoses. I think in doctors' offices, we all don't have enough time to really delve into depth and sometimes rely too heavily on what the lab tests show. I've also seen people say, well, all your antibodies are negative, you don't have an autoimmune disorder. And that's not correct either.
So switching gears a little bit, how do you distinguish Parkinson's, PAF, and MSA? And I know we didn't really talk about PAF or Parkinson's, but in terms of the synucleinopathies, how do you figure out which is which?
So there are characteristic features of Parkinson's disease, and that's stiffness, slowness, and tremor. And all patients with Parkinson's disease can get autonomic problems. In fact, most of them do, but it typically comes on a bit later in the course. So we wouldn't expect someone who just has a little bit of tremor to have very severe autonomic failure. That would make us maybe think a little bit about MSA. But as I was mentioning, the criteria are really only relative to what we think is the probable thing going on. But MSA patients typically have what we call atypical Parkinson's disease. In other words, they often don't have a tremor, which would be unusual. Most Parkinson's patients have that typical tremor that we see. And when we see that tremor, we're less likely that it's going to be MSA. And then Parkinson's patients tend, again, not to have more severe autonomic troubles until later on. PAF is a challenging one because it's sort of what they call a diagnosis of exclusion. So it's someone with autonomic problems who looks like they have autonomic failure, but you don't know why. And you examine them and they don't really have anything that looks like Parkinson's. No tremor, no trouble walking, and so on. And so we just give them the blanket diagnosis of PAF. Again, we're hopefully have some tests coming out soon that will tell us from a skin biopsy or another or other testing that they have this alpha-synuclein problem, and that will be very helpful to tell them it's neurodegenerative.
So I'll do 2 more questions because I know I don't know how short you are on time. I'm sure you have busy clinic days ahead. So can you talk a little bit about voltage gated calcium channel and potassium channel antibodies and how they relate to, they're rarely found in dysautonomia patients. Are they part of rare autonomic disorders, or are they part of other disorders that are rare that just happen to have some dysautonomia in them?
I think the latter. So classically, calcium channel antibodies are associated with the Lambert-Eaton syndrome, and patients with Lambert-Eaton syndrome do have autonomic problems. Typically have other problems that are more pressing, but they can get orthostatic hypotension, dry mouth, constipation, and so on. And potassium channel antibodies, can be associated with a variety of things, including a disorder called limbic encephalitis, which is mostly a brain disease that causes seizures and confusion and so on. But they can have some dysautonomia, usually excessive sweating, wide variations in blood pressure, heart rate, or a disease called Isaac's syndrome, which is where the muscles get real twitchy and stiff. And same thing, they can have fluctuations in blood pressure and so on. So now the same rules apply about antibodies. The potassium channel antibody and the calcium channel antibody both have false positive rate. So there's some percent of normal people that have those antibodies. So there may be a scenario where they aren't all that meaningful. Someone in the chat asked about checking for antibodies after getting a dose of IVIG. So IVIG is a whole bunch of antibodies from lots of people, and oftentimes we see low levels of all these antibodies if you check it after IVIG. So that can lead to some challenging, trying to interpret these things in the context of someone who's already on treatment.
So we saved the best question for last. It's probably a whole lecture unto itself, but we'll give you a minute to answer. What is your advice, and what is the general advice of the autonomic research community to an assortment of dysautonomia patients on the COVID vaccine? Should our patient community be vaccinated? Are there certain diagnoses where we have to be a little more careful, or I mean, I think everyone needs to consult with their doctor, probably, if they're concerned, but do you have sort of any helpful advice on that? Because I think a lot of patients want to get it, but they're a little bit worried that it's going to cause a flare of their autonomic disorder.
Yeah, it's a good question. And I think I don't have the precise answer for a lot of reasons. Number one is these vaccines are really quite new. We don't have years of experience to know. But the vaccines are also, well tolerated. I think if you were to weigh the risks of getting COVID versus the potential risks of a vaccine, there's no question that vaccine would be a better thing. So I think the question comes about because of the concern about people with tendency to immune diseases. Can they get a flare-up after a vaccine? I mean, the purpose of a vaccine is to stimulate your immune system. That's what it's meant to do. But I think right now we're coming down on the side of, given what's going on with the pandemic, that getting a vaccine is what I recommend for my patients. Of course, talk to your doctor. There may be specific situations that will change that argument. But so far, even in patients with autoimmune diseases, we haven't seen a major signal in terms of worsening after vaccination. We're talking about things like MS patients and encephalitis patients and even our autonomic patients that I look after. But that's just personal experience. I don't know. We don't have the long-term data to really know as yet. And of course, most of the vaccinations have been around high-risk people and older folks. And so a lot of our dysautonomia patients are younger. And as of now, dysautonomia in and of itself is not on the list of high-risk conditions. So it may be a relatively fewer set of people that have been vaccinated so far. So that's a roundabout answer to say I would recommend it, but talk to your doctor.
I want to last question. I said that was last, but you just said something. So to clarify, is dysautonomia a diagnosis? This causes a lot of contention.
Oh, thanks, Lauren. We've had this discussion before. I think it's not. I think dysautonomia is a description of something wrong. It actually means something wrong in the autonomic nervous system, and that encompasses a huge number of things. So I think we do, as a group, need to be much more precise in our definitions. And I'll tell you that the vast majority of the referrals to our autonomic clinic are referrals for dysautonomia, and that means everything from I'm a bit fatigued, I have pain in my feet, to actually things that we would consider to be dysautonomia. You and I have had this discussion about whether dysautonomia includes autonomic failure or not. I think in the broad sense it does, but we do need to be much better at naming what we're talking about, and that's a problem in the field, a problem we need to solve and work on. So
I think it's a problem beyond the field. I think there are a lot of doctors who are trying to help their patients. They don't really know the details of how to do this. So they'll recognize there's an autonomic problem or potentially an autonomic problem. They diagnose dysautonomia, and then the patient wants to know what's the cure for dysautonomia. And I'm like, well, which one? So it's a matter of clinician education, I think, and also empowering patients with accurate information so they can go back to that doctor and you say, please tell me which one I have, if you can. And the problem is that they can't. That's probably why they're diagnosing generic terms like dysautonomia.
For sure.
Uh-huh.
It's like saying, well, you have a brain problem. I'm like, okay, well, I knew that when I walked in the door. What kind is it? And I think you're exactly right about that. And so we have a ways to go. I think at least having a term that, you know, points into the right part of the nervous system is useful. But I think we probably need to talk about dysautonomias where the autonomic nervous system is overactive or underactive, or is is affecting, it's causing nerve damage versus not causing nerve damage. So I'll work on that for you, Laura.
Dr. Tapara, do you have any closing thoughts? I know we sort of didn't hear from you too much in the Q&A, but thank you so much for joining us. We're always excited to meet new autonomic neurologists. Oh, you're on mute. There you go.
Sorry, can you hear me? Yeah, thanks for the invitation, and I'm learning a lot and still have lots to learn. So,
well, as we all do. So thanks so much, everybody, for tuning in. Thank you to the doctors for lending us their afternoons and their expertise. And anyone who didn't get to watch this live, we recorded this and we will be emailing it out to everyone who registered for the webinar. So thanks very much and have a great day.